Well, hello providers, and welcome to the Urology Update series known as For Your Intelligence. I'm your host today, Dr. Eric Freedman, and I am a urologist practicing in Folsom, California. I opened a practice there by joining Dr. Javidan, who practices at Mercy San Juan, with a urology practice known as Advanced Urology. And that office opened in September 2020, kind of right in the midst of COVID. This update series is designed for providers to bring you up to date, essentially, in some of the newer things that are going on in urology and the information that we feel is important for you to know because your patients are already getting an inkling of this. I have over 25 years of experience as a urologist. I really do a little bit of everything. I did a subspecialty training in reconstructive urology and pediatric urology many years ago during fellowship years. So let's get right into this important topic at this stage of the game. And I should say that I have no financial disclosures for you, and that this is an accredited CME presentation. So the topic for today is really the major shift that's occurred in the BPH pathway treatment. And the focus now is on preserving bladder health, and we're going to get into some of the ways that we can do this. And a lot of this is new information, and I'm excited to be presenting this to you. So the BPH care pathway really has changed now, and based on three new developments. One is a better knowledge of the pathophysiology of BPH and obstruction. Secondarily is the growing amount of information about toxicities of BPH medications and their ineffectiveness in preventing the bladder deterioration that occurs with obstruction, and the new developments in minimally invasive surgical treatment. So these three things combine to create a change for us in how we manage BPH. And, as primary care providers, why should you be interested in this topic? Well, you're all aware probably that BPH is the number one reason why primary care sends patients to a urologist in the first place. And this is by a huge margin. And, BPH is very, very common. Around the age of 50, it's 1 in 2 men, and of course it goes up from there, increasing in prevalence with every decade. We typically say that by the time men reach 80, probably 80% of them have some degree of obstructive BPH. And of the men affected with BPH, almost all of them say that it has an impact on the quality of life. And why is that? Because your bladder starts running your life. And when you're getting up multiple times at night, where you're racing to the bathroom, the minute you walk into a restaurant and searching where the bathrooms are, that is going to limit your ability to travel and do many things, and also disrupts the partner's life and the partner's sleep. So there's quality of life issues with, both the man and the partner. And these changes and experiences that the people have, the symptoms, that really drives the search for treatment to improve these and prompts people to have referrals. And if we look at the BPH landscape this last year, 2020, it's estimated that there's over 40 million men in the U.S. Who have BPH symptoms. And about only 1/3 of them actually actively go to the primary care and seek any kind of help. So it's a huge number of men who are undiagnosed, and therefore the patients that you see in your office with BPH symptoms, or what we call lower urinary tract symptoms, or LUTS, that's really the tip of the iceberg, hence the image on this slide. And of those patients who are treated for BPH, more than 2/3 of those start off with medications typically prescribed by PCPs. The commonest would be alpha blockers, such as Flomax and Urocuff, and the 5-alpha reductase inhibitors, such as finasteride, would be secondary. And of those patients who start medications, 1/3 of them stop those medications within 6 months, typically because of side effects, or their ineffectiveness, or they're too costly, or they just don't want to be on medications. And 1/3 of the patients are just on watchful waiting, which means, as a primary care provider, they have symptoms, but you're saying, well, you don't really seem too bad. We don't need to do anything about it right at the moment. And only 2% of all the patients with BPH who get referred to urologists actually end up getting any kind of procedure. So, I mean, that's a tiny, tiny number of all the patients. And part of the discussion is that's probably actually not a good thing for men. So we talked about a lot of these men are getting started on medications, and we know a lot of studies have shown that these are not really very effective, either the alpha blockers or the 5-alpha reductase inhibitors, or the medications, such as Viagra, and even in combinations, not very helpful. They can improve men's flow rates, really just maybe 2, 3, 4 points, nothing compared to any kind of surgical interventions. And not only are they not very effective, but they don't prevent the bladder damage that occurs over time with obstruction, and we'll talk about that in a second. And on top of the ineffectiveness of these medications, the men don't want to take medications in the first place. And many men are already taking, handfuls of medications. This is something we call polypharmacy, and this is really epidemic in our society today. And most men, when they go to a specialist of some sort, another medication is added into the mix. And while this is making us all live longer, it's very, very costly, and we don't really understand what's happening in the patient's body, metabolically speaking, with all of the metabolism of these multiple medications and how they're interacting with each other. And Sir William Osler, many years ago, said the person who takes medicine must recover twice, once from the disease and once from the medicine, and we feel this is very true. And some of these emerging drug toxicities that you may or may not be aware of, anticholinergics, for instance. So that's the oxybutynin class of drugs. Very high risk of dementia if people are taking these over a course of 3 years or longer. And this is an article published in JAMA in 2019. So we have to be cautious with that. And let's face it, the people who have early dementia or Alzheimer's a lot of times have overactive bladder symptoms and what we call bladder instability. And these are common medications that they're put on, so we have to be very cautious. The alpha blockers, you're all very familiar with a lot of the side effects, the retrograde ejaculation and the fatigue and potential orthostatic hypotension. But there's also some studies emerging that say long-term use, in particular Flomax, there may be an increased risk of dementia. We know there's an increased risk of ischemic strokes, especially upon starting the alpha blockers. And ophthalmologists really hate these medications because they have all kinds of problems with visual acuity and recovering after intraocular surgeries and things like that. So, you must be aware of these and let your patients know about these toxicities. The 5-alpha reductase inhibitors, I've already mentioned, Proscar and Avodart are the commonest ones. But there's an increased risk of depression, increased risk of suicide, increased risk of metabolic syndrome, and certainly, obviously, there's ejaculatory and erectile dysfunction. And there's something you should be aware of because it's important to let your patients know. There's something called post-finasteride syndrome. And this is for patients who have been on these drugs for a period of time. If they have sexual dysfunction and you stop the medication, they may not recover their sexual function. In other words, they can have permanent sexual dysfunction, and that's known as post-finasteride syndrome. And pretty important to let your patient know about that because they're going to be pretty unhappy if they're put on a medication that gives them a permanent side effect. These patients can't donate blood, and the biggest concern we have with these nowadays is because it drops the PSA, and the typical reality of what we see is that within 6 months, most people's PSAs are going to be chopped in half. And then they should remain stagnant at that half level and should not be rising as long as the patient's on finasteride. And unfortunately, what we see is that when the PSAs get chopped in half, people miss the boat when the PSAs start rising, that this is an early sign of prostate cancer. And a big study that was published at a JAMA in 2019, a VA study, 40,000 men, found that of those patients who were on 5-alpha reductase inhibitors and were diagnosed with prostate cancer, they had a much higher incidence of aggressive disease and metastatic disease and eventually death from prostate cancer because there was a delay in their diagnosis because their PSAs were lower. So, you must really be aware of what you're doing to the patient's PSAs if you're going to be utilizing this drug. And in fact, I would take it one step further and I would say that if you're one of those PCPs who really, have been trained, we shouldn't even be screening for prostate cancer in the first place, and you're not doing PSAs, you should never be putting your patients on 5-alpha reductase inhibitors because you can really miss the boat and you can put their health at risk in terms of developing prostate cancer. So when primary care physicians put the patients on medications, one of the questions I have for you is, well, how do you follow your patients once you start them on BPH medications? And if you think about it, really in terms of your office practice, you don't have a really good way to follow these patients. And this is a bit unusual because I can't think of any other kind of medication that you start a patient on that you don't follow somehow afterwards with some kind of marker or a test. If you start a patient on an antihypertensive medication, you're going to have them come back to your office and check their hypertension or have them check it at home. If a patient started on some kind of a diabetic medication, you're checking their blood sugars and their hemoglobin A1C to see how they're doing. A patient who's on lipids, we're checking their cholesterol and their triglycerides, etc. So, there's very few other medications that are used in such a broad fashion by primary care that you don't follow the patients. You start a patient on Flomax, and the patient comes back and you say, how you doing? And the patient says, well, I think I'm better. And that's the way it ends. And the patients are left on these medications for years and years and years until they finally fail medications, but that can really be pretty late in the situation. So some basic investigations that can be recommended to you to follow these patients. Certainly a baseline PSA is always a good idea because you want to know who's got a high PSA and who should be followed more closely. Number one, a PSA gives you a pretty good estimation of somebody who has a large prostate volume. You want to know what their renal function is like, starting off if they have lower urinary tract symptoms. And it's not unusual, and I don't think it's overkill, to request a screening renal ultrasound and a post-void residual to check on how the patients are emptying their bladders, because this can be a very silent process. In a urologist's office, we oftentimes use what's called the IPSS score, or International Prostate Symptom Score, or the AUA score. And you'll see that in referrals coming back to you from the urologist. They'll say, well, the patient's IPSS score was 20 or 25 or 10. And this is based on a scoring system. And the patients fill out these questionnaires, and the scores are 0 to 5. And then there's also a quality of life questionnaire. And so this really helps to quantify when we start patients on treatments and before we treat the patients, how do they feel they're doing in terms of their own bladder and symptoms? And then how do they respond to medication? So we use these numbers all the time. And this would be a very, very simple thing to institute into primary care offices. Our office can supply you with these kind of score sheets. You basically get the MA to help the patient, answer the questions, and basically the MA, can total up the numbers. And so when you're seeing the patient, you're just quickly looking at the sheet and say, oh, I see your score is 25. You're not on any BPH medications. You haven't seen a urologist. Yeah, hey, I think it's time that, we get some kind of assessment. So anyway, this score sheet can be very helpful to quantify your patients, once you're starting medication. Well, so that kind of talks a little bit about where we're at with medications with BPH. There's no really new medications that are on the horizon or on the development. And so we're stuck with the medications we have, which, as I said, have poor effectiveness and can have a lot of toxicities. So the other new piece of information that's come along is a better understanding of the pathophysiology of the pump or the bladder. And what we know is that if you take any muscle and you put it to work, you get hypertrophy. This is true of skeletal muscle. This is true of involuntary muscle. And, a lot of people don't really understand what's going on with the prostate, but they do understand what's going on with another pump muscle, which is the heart. So if I can do the corollary and compare BPH to obstructive cardiac outflow, so that could be either aortic stenosis or some other valvular stenosis or, severe hypertension where the heart is under stress, we know what happens. Any cardiologist following these patients with echocardiograms knows that first the myocardium hypertrophies, trying to compensate to keep the flow going, but then secondary there's dilatation. And along with dilatation comes also increased reduced ejection fraction, which means with each pump of the heart, there's an increased amount of residual blood in the heart. So when we talk about the heart failure, we're talking about reduced ejection fraction, and we talk about bladder failure, we're talking about increased post-void residual, but the phenomena is very, very much the same. And be aware that BPH is a progressive obstructive disease, just like cardiac valvular disease. You don't just find it one day and it stays stable. And I think this is one of the difficulties in when primary care comes to treating BPH, is that you don't have good ways to follow the patient, and you can't assess when deterioration is actually occurring. And we know that outflow obstruction of the bladder, whether it be due to prostate or scar tissue like strictures or anything else, can cause really severe damage to the bladder. And any young boy who's born with posterior urethral valves and obstruction in utero, can have severe dysfunction of their kidneys and their bladder, for the rest of their life. So we know that what obstruction causes. And we also have a better understanding now of the pathophysiology. A recent study just came out at the end of 2020, looking at 50,000 men and observing their bladder physiology using a new non-invasive test called the Urocuff test, and we do this routinely in the office nowadays. And basically, the man simply voids into a funnel, and it's measuring the flow rates, and it's deciphering bladder function. Anyway, what we found with this is that men's bladder appears to have its peak function in terms of forcefulness around the age of 62. So this is a relationship in that the bladder is trying to compensate for prostate enlargement, which really starts to become more prevalent after the age of 50. And after the age of 62, we see with these bladder physiology studies that the pump starts to weaken. We also know that the maximum flow rate, which is pretty good when men are teenagers or in their early 20s, really starts to continue to deteriorate and reduce as men get older, well up into their 90s. This was a study looking at men aged 30 to 90. Now, we all want to maintain our physiology and our good looks and our activity, but we know that no matter how hard we try, we're not going to look 20 for our whole lives, and our muscles of our body are not going to function like that either. So what we see in bladder physiology studies, again from this paper, is that the voided volumes over time also decrease. So here you have a situation where the bladder is getting weaker, the flow rate is going down, and the voided volume is going up. And what do we see? No surprise. In the last slide there is the post-void residuals begin to climb. So your bladder gets weaker, it's not emptying as efficiently, and you're starting to carry more and more urine in your bladder with age. So what is that? That's really congestive heart failure, of your bladder. So with this information, we have deciphered what we call the bladder life cycle, which we can chart and find out where is the patient in this natural life cycle. And the green zone on the bottom right is kind of the normal zone. So the patient has normal pressures when they're urinating, a pretty normal flow rate, and the patient empties their bladder pretty well. In other words, they have a low post-void residual. And then they get into the compensatory phase. So in the other slide, that was around the age of 62, the peak compensation, where now the bladder is pushing with the highest pressures it has. The flow rate is still normal, and the person is still emptying their bladder. So all that's changed really is that the bladder is working harder to maintain itself. And then you shift into zone 3, the kind of pinker zone, where now what we see is the bladder still pushing with high pressure, but now it's beginning to decompensate. There's lower flow, and we're starting to get an increased amount of post-void residual, or the beginnings of bladder failure, bladder congestive failure. And then you finally get into the bottom on the left, where the bladder's failed, and the bladder's barely pumping, so you have low pressure, low flow, and high post-void residual. In terms of cardiac function, this would be end-stage congestive heart failure. So try to, when you think of your bladder, your patient's bladder, and try to help their bladders, take a thought back to what's happening to the cardiac function. Because if you wait too late, you get severe bladder damage, and really you get the point of no return. A severely trabeculated bladder, that's hypertrophy of the muscle, that in itself can cause obstruction of the ureters and hydronephrosis. You get retention of urine, you can form diverticulum, recurrent infections, bladder stones. I mean, these are all things we see all the time. And even if you do a TURP on these patients, a lot of times this is a bladder that's severely damaged and can't be recovered. So, be aware that BPH is not just talking about the prostate, it's about bladder preservation health. So BPH, bladder preservation health. And be aware that when you start patients on drugs, not only can these be insufficient, but they may delay the assessment of what's going on with that patient, so that by the time they come to the urologist, surgery can really be too late to prevent what's going on. And you should be aware that if we can disobstruct the prostate, so disobstruction, opening up the obstruction, you can preserve bladder function and you can prevent end-stage bladder dysfunction. And also it means you can get these patients off these toxic medications. So that's a relatively novel concept called deprescribing. And in urology, there's a very strong push now to be doing more disobstruction of these prostates rather than putting patients on medications. And we really are quite proud that we can deprescribe the BPH medications for a lot of these patients and reduce their burden of polypharmacy. So how many specialists do you send your patients to who actually take away medications instead of adding in medications? And one of the ways that we can discuss this with the patients is saying to them, well, what if I could get you off medications, which number one, aren't working and are giving you side effects and are costly, with a relatively low risk, durable, minimally invasive procedure. Oftentimes can be done in the office and with quick recovery. And when put in that light, a lot of patients will choose to have a procedure that is a disobstructing procedure rather than remain on medications for a long time. And you should really be aware of this, because remember that patient satisfaction is based on how the patients feel that you're doing in terms of presenting information, helping them along. And how do you think the patients feel when they do research and they find for themselves some of these minimally invasive treatments and go to urologists and get a procedure and get off medications, and then they're circling back to the primary care physician for their blood pressure check or their diabetes or whatever, and the family doctor says, well, how you doing with your Flomax? And they go, oh, that crap, I had a procedure, I'm doing great, I feel great, and my urologist got me off the medication. So, you want to be part of the team and you want to help your patients. And by holding back this new kind of information for them, I think you're making their search more difficult, and they're not going to be overly satisfied. So these advances in minimally invasive therapy really have allowed us now more than ever to intervene earlier in this BPH pathway. So we're talking about trying to intervene in the state where the patient has gone into compensation, but the bladder has not failed. So the red arrow is kind of pointing to the perfect timing to intervene with a disobstructive procedure. And you can understand that if the patient's just sitting on an alpha blocker or some other BPH medication, or they're just taking over-the-counter herbal therapies like saw palmetto and various different supplements like that, that they can shift from the green zone to the white zone above with really minimal symptoms, and no one will really know about it, and then they can fall into the decompressive sort of phase. And again, it can be a pretty silent process. I mean, we've had patients present in blatant urinary retention. They get catheterized for 3 liters. They have bilateral hydronephrosis. They have renal insufficiency, sometimes permanent. Sometimes they need to go into dialysis. And they feel like they were peeing okay, except maybe a little more urgent. Maybe they were starting to wet the bed at night. And that was about all the symptoms they had. So it can be a silent process. And so don't get caught short. Try to get these patients assessed earlier so we can intervene earlier. That's pretty important. And this earlier intervention is now reflected in all of the urological guidelines internationally, not just the American Urological Association, the European, the Canadian, Australian, British. I mean, basically all of the urology associations now are talking about these things. So number one is the patients warrant having precision evaluation, which means back in the good old days, you sent the patient to a urologist. They either had a TERP right off the bat, or they got put on Flomax or finasteride, and they were just watched. But a lot of times, a generation ago, patients weren't having otherwise investigations. Well, nowadays, that's not true. A patient comes in with BPH, we're looking under the hood. We're getting a cystoscopy. We're getting a transrectal ultrasound measurement of the prostate. We're checking their PSA and their rectal examinations. We're checking bladder pressures. Sometimes we're doing ultrasounds of the kidneys. So this is all part of the precision evaluation to find out where is the patient in the bladder life cycle. And if they look like they're in a phase that warrants it, we'll offer them early intervention, and oftentimes first line as a minimally invasive therapy before they're even started on medications such as alpha blockers in the first place. And so this is the big shift that you need to be aware of. And of course, if you're referring a patient to a urologist, let them know that we are going to be doing this precision evaluation, and we're going to be looking under the hood. So, kind of warm the patient up to the fact, hey, I'm sending the urologist. It's very important. We need to get some diagnoses to understand what's going on. And again, you can use the corollary of the heart situation. If you were listening to a patient's heart and you heard a systolic murmur and you're thinking, geez, maybe this guy's got a little bit of early, aortic stenosis or valvular obstruction, you would tell the patient, look, we're going to send you to the cardiologist and they're going to do some tests. They're going to get an EKG and they're going to do an echocardiogram and, maybe some other various testing. So you let them know that that's going to happen. Do the same thing with urology. And as we talk about these new minimally invasive therapies, we now have the ability to use what we call precision sculpting of the prostate through a lot of these different fashions. And I'm going to go through 3 of the newer minimally invasive therapies that I think you should be really aware of. And the first one that really changed the game for urology and patients with BPH was Urolift by the company NeoTract Prostatic Urethral Lift System. And so this is FDA approved. It was originally developed by a group of biomedical engineers out of Pleasanton, California. So their head office is, just a short drive for us. I've been there many times to visit the head office. And this is offered as a one-time, usually office procedure that is a disobstructing procedure. So it's a mechanical, customized solution to what is basically a mechanical obstruction. And this can be offered as a first-line treatment. And if I show you very briefly the procedure, we place a scope up through the urethra to visualize the inner part of the prostate. And through this instrument, we can push on the prostate to open it up. A little needle crosses, applies a little tab on the outside of the prostate. There's a thin proline suture, and then there's an inner tab that we set. So the degree of pressure that we put on the prostate tells us how much we're opening up the prostate. And we put enough of these permanent implants into the prostate to give us really an open kind of appearance. And obviously with a larger prostate, we need more implants, and a smaller prostate, less implants. But basically 2 or 4 or 6 implants are pretty typical, and you can kind of see the before and after image. And actually true visual imaging, that we see kind of looks like this. And this can work very well for the patients with kind of medium-sized prostates, not really designed for patients with super large prostates. And so that's the importance of us doing a cystoscopy in advance, us measuring the prostate volumes and those kind of precise testing so that we can then decide who needs what, and we can give a more precise and personalized level of medical care. So the next procedure also is an office-based procedure called Rezum, and this uses hot water vapor that we inject directly into the prostate. And clinically, basically, it's also done with a scope that's going up through the urethra under direct vision. The prostate adenoma is pushing in on the urethra, so a small needle is delivered where we want it to be. Hot steam is injected through a hollow needle, basically for 9 seconds, and the hot steam denatures the proteins and the adrenergic nerves to cause relaxation of that part. And the percolation is only occurring in the adenoma, or what we call the central transitional zone of the prostate. And basically we've cooked that tissue, and then over the course of 1 to 3 months, the tissue resorbs because basically it's dead, and that takes pressure off the urethra, and the urethra opens up. And they basically 3 and 6 months data on Rezum really looks very, very good. In fact, might be even a little bit better than Urolift. The differences are the Urolift is an immediate disobstructing procedure, and typically, within a week or 2, patients are over the initial irritative symptoms and are really feeling good. With Rezum, it takes longer. Typically, we say to the patients it could be 1 to 3 months really before we're seeing the improvements. They begin to see some improvements, in the first few weeks, but it really takes a little bit longer. But both of these procedures are offered as office procedures. In my office, we also have laughing gas, nitrous oxide, that we give the patients to help them with sedation during these procedures. The last procedure is not an office procedure. It's a hospital procedure, but it's for very large prostates who in the past had transurethral resections or open prostatectomies, and now we have a really cool, high-tech, because it's robotic, kind of a system. So the patient's in the OR. We place a transrectal ultrasound like we do in the office, which gives us really 3-dimensional imaging of the prostate, and then we place a scope per urethra under direct vision, so we're visualizing the inner portion of the prostate. and then everything is kind of fixed in place. We take measurements of what part of the prostate that we would like to actually trim away or open up and resect, and we can adjust that. It's all fed into a robotic system, and then the robot uses a high jet of saline, which is physiologic, of course, sweeps back and forth, and actually is removing the prostate tissue just with the high force of the jet. And it's a customized shape depending on what we drew in the computer based on the ultrasound measurements. So completely customizable. You can do as much or as little of the prostate as you want, and there's no limit to the size of the prostate. We can do prostates, up to 200 and 300 gram size. Average prostates, typically, for an average male, in their 60s, let's say, 30 to 40 gram prostate, but some men have very, very large prostates, so this allows us to do that very safely. So that's just kind of a little quick overview of some of the new technology. So it's important for primary care to understand this new BPH care pathway. Number one, understanding, if we go back to the physiology, that is BPH is a progressive disease, and it does have very serious sequelae if these things are not diagnosed. So be aware of the bladder life cycle, and you want to ask yourself, where is this patient in the bladder life cycle? And if you don't know, you need to do some testing, or you need to get the patient into the hands of a urologist, because otherwise it's not safe. The other point that I made is that medications are ineffective in preventing bladder damage. We get patients who come to us who've been on Flomax for 15, 20 years, and now their bladders are shot. And we should have seen them a decade earlier. And be aware that men want to be off medications. They don't want more medications. And certainly they want to avoid side effects, especially the sexual side effects. So men are out there and they're seeking alternatives, and they're finding these alternatives on the internet. And it would be much better if it came from their primary care doctors and not from something they found out online. So the big paradigm shift in BPH care pathway that I've tried to stress here is, number one, earlier and very specific diagnosis, which requires some of the tests that I outlined before, and earlier disobstructing interventions. So we want to take away the obstruction. Someone's got, that aortic stenosis. They're followed by their cardiologist, and and they go and have an echocardiogram every year, and eventually the cardiologist says, your myocardium's thickened, your ejection fraction is going down. I feel like the heart is really starting to have some risk here, and it's time to send you to the vascular surgeon, cardiac surgeon, to get your aortic valve, fixed or replaced, or they're doing minimally invasive procedures nowadays. But that would be the natural transition. So you really have to think in those same terms with regards to your BPH patients. And these new minimally invasive therapies really give the patients an enhanced quality of life, much better than they get with medications, and a pretty good experience. These minimally invasive procedures don't have all the side effects that the older surgeries like TURPs and open prostatectomies had, but they're much better than medications. So they fit the bill of the patients who are having more symptoms or a larger size prostate than can be managed just simply with medications alone. And we want to reduce the burden of polypharmacy and, of course, all the toxicities that go along with giving the patient BPH medications. So we want to practice precision medicine, which means providing the patient the right treatment at the right time for that specific person. And to do that, we need to have a pretty specific workup and investigation. So I really want primary care to be our partners in this. I want you to be part of the solution and not part of the problem in the eyes of the patient. So some of the strategies that I outlined that can be helpful for you. So number one, consider using the International Prostate Symptoms Score Sheet in your office to track your patient's progress. Consider other diagnostic testings like a baseline PSA, ultrasound of kidneys, and post-void residuals. Consider earlier referral to ascertain where is that patient in the bladder life cycle before waiting for medications to fail. And I don't have any problem with primary care offering the patient an alpha blocker like Flomax as a short-term trial to see how they do, and also as a bridge to referral, because that can also be helpful for me when I see a patient who's been on Flomax for a month or two and they report good or bad or side effects or whatever. That's very, very helpful, to me to be able to move on. So I have no problem with that, but don't anticipate that starting a patient on an alpha blocker or any other BPH medication should really be a long-term option for them. And as I said, if you're not tracking PSAs before, and certainly at least yearly if a patient's on a 5-alpha reductase inhibitor, the patient should not be on that medication, and certainly don't prescribe it as an initiating factor. And if you see a PSA climbing when a patient's on a 5-alpha reductase inhibitor, get that patient to the urologist ASAP, because that's a very early indicator of probably aggressive prostate cancer. So when you're discussing BPH with your patients, consider discussing the minimally invasive surgical therapies, of which we have many options nowadays, and discuss with them also the option of, well, you could consider doing a procedure that could get you off medications that are giving you these side effects. So these are really some of the important strategies to help you out. And also stress to the patient that BPH isn't really about just the prostate. It's really about trying to preserve those patients' bladder health. Because what's going to bother that patient as they get older in age is the symptoms that their bladder is suffering from, not knowing whether they have a 20-gram prostate or an 80-gram prostate. But they certainly know if their bladder is waking them up, 4 or 5 times at night. So we want to try to preserve their bladder function so that men can have a good quality of life as they go through advanced age. So I want to thank you very much for taking out the time today to spend this time with me in this PCP update series. If you have questions on urologies that you would like a presentation or personal question, I love to get phone calls. My cell phone number is there under the mobile phone, 209-768-1958. You can put it on your speed dial. You can call me anytime with a question. It doesn't have to be a referral. We're going to be working with Tiger Text if you're working through the hospital system. The 2 other numbers there, that's the office number in Folsom and the fax number if you have any questions, and my email as well. So anyway, I certainly appreciate your time. One of the things that I was told that we need to cover very briefly in a CME is also a discussion about real live patients. So normally we'd be asking you to call in so we can have a discussion about questionable patients that you have that you need some help with their management. But in this case, I picked 3 patients that give us a little bit of an overview. So the first patient's an 83-year-old, has been on Flomax for 15 years, and he gets referred to the urologist because now he has bedwetting. And of course, unbeknownst to the primary care physician, is the patient comes in, he's got a post-void residual of 750 cc's, he's got no sensations of a full bladder, he's also having daytime urgency and leakage, he's wearing pads during the day, and he's wearing diapers at nighttime, and he's been wearing a diaper at nighttime for a year. And it took him a while before he had the guts to go to his primary care to ask for help. He's not had bleeding, he's not had infection, and he has, unfortunately, a degree of bilateral hydronephrosis, and his creatinine was 2.2. And so he was first treated with a catheter and then taught intermittent catheterizations, went on to have a transurethral resection because he had a very large prostate, but still had to be performing catheterizations at nighttime because of post-void residuals. So this is a patient that got into urologist's hands way too late, and it can be a silent process. So patient number 2, a younger guy, 55-year-old, presents with lower urinary tract symptoms and sexual side effects from his medication. He's on both Proscar and he's taking double-dose Flomax. He's complaining of fatigue, he's complaining of no ejaculation, and he's complaining that his erections are becoming softer over time, and he's only 55. So he gets in the hands of the urologist, he has a full workup, he's deemed to be a good patient for a minimally invasive surgical therapy. He has a Urolift with excellent results in terms of improvement of his lower urinary tract symptoms because it's a disobstructing procedure rather than just, tampering down his symptoms. And he gets off his medications, and, 6 months later, the guy's happy as a clam. Sexual functioning's back to normal, and he feels like he's 18 again. So that's a real life story of patients that we see all the time. The third patient, it'll wrap it up, is a 67-year-old who presents with acute urinary retention, and the patient's been on Proscar for 6 years and only had 1 PSA check in that 6-year period of time. That was 3 years ago, and his PSA was 3.8. And he had already been on Proscar for many years prior to that. So, a lot of primary care providers are still under the belief that if your PSA is under 4, that's safe. I mean, that's Boulder Dash. Forget the 4. The safest PSA is that it was the same number as it was last year. And if you're not checking PSAs, regularly, you don't know that. Patients with low PSAs have a much lower risk of prostate cancer, and they don't need PSAs annually. But a patient who's on finasteride, who's got a PSA of 3.9, we already discussed that the finasteride cuts your PSA in half. So what are we really saying? This patient's PSA is almost 8. And if you saw a patient with a PSA of 8, you'd be thinking, well, maybe we want a urologist to assess him. Anyway, he gets to the urologist, and unfortunately he went into urinary tension because he's got bad prostate cancer. And if anyone did a rectal examination, they'd feel a rock-hard prostate, lumpy, very suspicious. The patient had prostate biopsies, and he ended up having prostate cancer and had to have treatment for prostate cancer, which eventually took care of his urinary retention. But again, this is stressing that if a patient's on a 5-alpha reductase inhibitor, you really need to be checking PSAs on a regular basis. So that kind of wraps up our conference and our Urintelligence update for today. I want to thank you all for your commitment to excellent patient care. And as I said, if you have any questions, urology or otherwise, please feel free to contact me at the office, and I'll put that slide back up there. So my personal cell number is 209-768-1958, and the office phone number 916, it should be, sorry, 936-1010. And that's the office in Folsom. So thanks again for your time, and that wraps up our show for today.